presentation. Now I would like to invite Dr. Naveen. He is a consultant pediatric ophthalmologist at Purple Eye Care Hospital, Chavara.
Good morning. In my talk, I will be talking mainly about the etiology of pediatric or congenital cataract and how a pediatric cataract or pediatric eyes is different from an adult eye. So, in the etiopathogenesis, the causes for a congenital cataract is multifactorial, but the main mechanism behind a congenital cataract are oxidative damage, genetic alterations, or metabolic alterations. So, keep this in mind in the upcoming slides. We can classify congenital cataract in many ways. One way of classification is based on the laterality. So, it can be bilateral or unilateral. The cause for bilateral cataract is extensive. So, like Dr. Lucy told, most of the bilateral cataracts can be idiopathic. So, other causes for a bilateral cataract are maternal infections like torch infections, then metabolic and systemic disorders like galactosemia, diabetes, Lowy syndrome, Alport syndrome. Then any ocular malformation or ocular syndromes like anterior segment dysgenesis, aniridia. Any chromosomal abnormality which causes genetic alterations like Down syndrome. Then isolated hereditary where no other systemic findings will be there, and it's usually autosomal dominant. Then another cause is treatment induced or iatrogenic, like the patient is on steroids or had a radiation exposure or after any after retinal surgeries. Coming to the unilateral cataract, like the bilateral cataract, idiopathic comes first. Then other common causes are trauma in childhood. Then secondary we have like chronic inflammations like uveitis or retinal detachment. Ocular malformation also comes in unilateral cataract like persistent fetal vasculature or anterior segment dysgenesis. Then treatment induced like steroids, radiation, etc. So, as I said, idiopathic forms more than 50% of the congenital cataract. Some associations are any insult during in the antenatal period like maternal preeclampsia, multiple pregnancy, placental insufficiency, or any drug intake during that time. Low birth weight is also a association. So, the pathogenesis they say is the prenatal oxidative stress which causes exhaustion of the glutathione. That may be a possible association. In the genetic mutations of the genes which code for these lens proteins like crystallins are commonly described genetic pathology. It can be autosomal dominant, autosomal recessive, or X-linked. In maternal infection, as I told before, torch like toxoplasma, rubella, cytomegalovirus, herpes, and even syphilis can cause congenital cataract. In developing country like ours, rubella is commonest. So, a virus it can affect the infection can happen in the first trimester or later in the trimester. So, if it's in the early in the early trimester, so the virus can enter to the developing primary lens fibers, and it can cause interfere with the protein synthesis, which lead to the cataract. In the last trimester, the infections rarely reach the center of the lens, but still it can cause cataract by metabolic disturbance. This is a case of congenital rubella. You can see a membranous cataract with fundus showing salt and pepper retinopathy. In the metabolic and systemic disorders, usually such cataracts are bilateral and often have characteristic appearance, and the children will have other systemic involvement, and cataract may not be the presenting symptom. So common causes are galactosemia, diabetes, Wilson, hypoparathyroidism, Alport, and Lewy. This is a typical sunflower cataract seen in Wilson disease. Cataract can also be associated with chromosomal abnormalities, like Downs is a common association. This is a Down syndrome child. In the ocular malformation, anterior segment dysgenesis is a common cause, and here you can see a Peters anomaly. Another common cause, especially in a unilateral cataract in infant, is persistent fetal vasculature. Here you can see prominent ciliary process and an ultrasound showing the stalk. The hereditary cataract can be isolated where it's a non-syndromic, and you can see a family with cataract history. In the acquired causes, we have trauma as one of the common cause. Here what happens is that trauma causes damage to the lens capsule, and which causes hydration of the lens fibers, or it can affect the metabolism, leading to cataract development. Also, chronic inflammatory pathologies can cause oxidative damage, leading to cataract. Long-term steroids can affect metabolic alteration and osmotic failure, thus resulting in cataract. And then we have surgery or iatrogenic cause. So here you can see a traumatic cataract. The left one is a penetrating injury, and the right showing a rosette cataract after a blunt trauma. This is a case of juvenile idiopathic arthritis with pupillary membrane, and the other eye showing thiazical changes. So a few slides on morphology. Because of the layered development of the lens, the timing of the intrauterine insult can be judged by the location of the opacity. If its insult is very early, the embryonic nuclear cataract may happen, or if it's little late, it can affect the fetal nucleus. And also zonular cataract may be, the insult may be little late or in the childhood. Polar cataract are usually suggesting congenital onset. These are a few slides regarding the morphology. Upper slide you can see zonular cataracts, then cataract pulverulenta, we have anterior polar cataract, oil droplet sign, then posterior polar cataract, we have sutural cataract. So this morphology will also help us in giving clue regarding the association. Like in case of anterior polar cataract, we can think about anaradia or anterior segment dysgenesis. Oil droplet cataract seen in galactosemia. This is a lamellar cataract, which is a common congenital cataract. You can see a clear center, and this is a nuclear cataract where the nucleus is affected. This is a blue dot or a Serlian cataract. This is a copper cataract or central pulverulent cataract. And we can see the oil droplet reflex in an anterior lenticonus. So about the pediatric versus adult cataract, like pediatric eye is not merely a miniature of the adult, it's a system under evolution. So as you know, the eyes are hyperopic in the early period and shift to myopic around 7 years. So the axial length increases significantly from birth to adulthood, but there will be compensation by the cornea and the lens, which is known as emmetropization. But this compensation is lost in post-surgery patients, resulting in significant myopic shift. As you know, the axial length increases, but the power of cornea and the power of lens decreases as the child grows. So the pediatric eyes are small and they have scleral rigidity is very low. So we need to suture the wound. The anterior capsules are highly elastic, so the rhexis can run out. The lens is soft and the vitreous is well formed. And post-op we will have severe inflammation because of the immaturity of the blood aqueous barrier. The chance for posterior capsular opacity is very high, and the eye is evolving, so the refractive status is constantly changing. the risk for glaucoma is high, and there is risk for amblyopia. This is a case of posterior capsule opacification. So to conclude, etiology of a pediatric or a congenital cataract is multifactorial. Still, more than 50% is idiopathic, and based on the laterality, location, and morphology, we will get clues regarding the etiology and time of insult. And pediatric eye is not a miniature adult eye. This is my reference. Thank you.